Good evening, everyone, and all dignitaries, MMC, expert, Dr. Gangurde, then expert teachers, presenters, board team participants, Team Mahapi members, then Team Mahapi Case Challenge coordinators, and all Mahapi members and PG students. Till now, since January, we have brought many academic programs with the by Tuesday Takes, then Mahapi Subspecialty, then Mahapi this Case Challenge also. And this is one of the hit program of last year, which Dr. Mahesh Mote sir has taken forward last year. And then now it is in second year, and it may go for many years to come with the new teams of Maha IP. So today, today we have guest of honor, Dr. Vasant Khaladkar sir. He's a ID chairperson. Then we have expert Dr. Mahesh Moite sir from Panvel, senior pediatrician and intensivist. And then we have another second expert, Dr. Narendra Nanewdekar sir also. So, and we have two teams, both teams containing stalwart IIPians, academicians. One is from Raigad IIP, Dr. Chandorkar sir, Dr. Abasaheb Patankar sir, and Dr. Sunil Seth sir from Mahad. And the second team is from Kolhapur, Dr. Uday Patil, Dr. Mahesh Kore, and Dr. Venkatesh Tarkasban. So, without wasting time, I straight away request Dr. Deepa ma'am to take us further in this episode. Thank you. Over to you, Deepa ma'am.
Thank you. So we are again here with yet another interesting session of Mahapi Case Challenge. And today's, I think the session will be more interesting, as we are having stalwarts, not just as experts, but also the presenters and the participant team also. So it will be very interesting to see how the case discussion goes on. So to start with, I request our Mahapi President, Dr. Ramakant Patil, so to give his wishes for this session. Over to you, sir.
Deepa, for handing over the baton to me for a minute. And what an excellent, successful program this has been. Thanks a million to Dr. Pramod Kulkarni and his able team, Dr. Anjali, Dr. Deepa, and Dr. Trupti. Wonderful. And in addition to this, what this case challenges is really enthusiasm. Everybody joins with enthusiasm because we always like to face challenges. And as Morgan Freeman has said, challenge yourself. It's the only path to have all-round and multifaceted growth. And here we are having these challenges. And we have got a really stalwart presenter, my homegrown buddy, Dr. Tushar Godbole, renowned endocrinologist, Dr. Sushruta Deshmukh ma'am, and that will be definitely a wonderful and delight to see this, witness this. And it is really who's who of Maha IIP is there, not only Maha IIP, of CIIP also. We have got guest of honor, emeritus at least for coming 2 to 3 years, Dr. Vasanta. I call him as Vasanta, but I will have to call him from next year as a president, sir. So Dr. Vasant Khaladkar is there as a guest of honor. My friend, philosopher, Dr. Mahesh Moite, as today's one of the expert. My buddy in executive board member CIIP in 2022, an academician and looking after PALS for so many years, Dr. Narendra Nanewdekar. And what to say about the teams which are going to face this challenge or crack the tough nuts being presented by Dr. Sushruta Deshmukh and Dr. Tushar. And friends, our Bhishma Pitama of clinical pediatrics, Dr. Amdekar always says, it is not what we are going to have a diagnosis, it is the approach. And who else then will demonstrate it to us, like Dr. Mahesh Kore. Ably contributing will be Dr. Uday Patil, Dr. Tarkasban. And from Raigad, we have got again greats like Dr. Abasaheb Patankar, Dr. Sunil Seth, and Dr. Rajesh Chandorkar, who is being my friend in last year's Maha IAP. And not taking much of your time, I am also all ears to see how the saga unfolds and how we are going to witness this treasure hunt. So I wish all the best to presenter also, because today's experts are, as Dr. Deshmukh Madam has said, we are just, but they are definitely going to guide you, and we are going to have wonderful session today, as the teams are great. Over to you, Deepa. Thank you for your giving me an opportunity.
Thank you, sir. So now I request our main coordinator of this Maha IP Case Challenge, Dr. Pramod Kulkarni, sir, to brief the presenters as well as the participants regarding the session and any specific instructions to be given. Over to you, sir.
Thank you, Deepa. Good evening, everybody. Let me tell you, personally for me, this is going to be probably the best of the episode one can have. Best of the academic discussion it is expected to be, anticipated to be. A disclaimer first from my side, my efforts are no less than efforts of all my team and Maha IAP. Okay, surrounded by all the heavyweights around today, from the IAP, from the academics, from practice. I'm feeling academically I'm a novice, and IAP I feel like a minnow here today. So what to say? Galaxy of people around, every contestant.
So you're muted, Prof.
Pramod sir, you are muted.
Pramod
Is
sir?
he there?
Probably he's lost the
Ah,
connection.
he's there. He's there. He
there?
joined. Pramod sir.
Seems to be frozen.
Am I audible?
Yes, sir.
Yes.
You are audible.
Okay, so everybody can crack any of the world's cases before any of the topmost clinician of world. So this is the stature of the contestant today, tonight, and let us see how it unfolds. My request to the contestant: don't hit the diagnosis on first ball. Dr. Mahesh, Dr. Abha, Dr. Sunil, everybody of them, and just let it run through its proper time. That's my request. One request to the audience viewers, please don't comment in the chat box. I know you all can crack the case. So
Probably we are losing him.
Yes, yes.
Yes. I think we'll move forward.
Yes.
I request Dr. Amol Pawar, sir, to kindly introduce our today's guest of honor, Dr. Vasant Khalatkar, sir.
So here I am to introduce our dear friend, Dr. Vasant Khalatkar, sir. He is chairperson of ID chapter. Then he's consultant pediatrician and neonatologist. He has done MD. He is fellow of IAP. Then he has done postgraduate diploma in pediatric infectious diseases. Then he has done his fellow guide diploma. He has done this diploma of child health. Then he is a national convener of ID chapter 2023. Then he was a national chairperson of pediatric neurology chapter last year 2022. Then he was organizing chairperson of Pedicon 2018. Then he was past president. He's past president of COMHAD. Then he's director of Colors Children Hospital for pediatric intensive care in Nagpur. He was EB for 2 terms. Then he's editor of Pediatric Neurology Bulletin also. And he is a recipient of many awards, as you can see in the chat box. Then the experts, today's experts are Dr. Narendra Naniwadekar, sir. He's a past EB member in 2021 and 22. Then he's a past IAP ALS national convener in 2021 and 22. And he's chief coordinator of parenting guidelines, which we have translated in last year and this year also. And also the Hindi translation has been started with the new team from many states, many Hindi speaking states also. Then another expert He is the pioneer of this Maha IP case challenge, and he is Dr. Mahesh Mohite sir. He is a senior consultant pediatrician from Panvel. Then he was chairperson of pediatric intensive care chapter in 2022. He was EB member. He has held many posts. He has not given his CV, but he is recipient of many awards. Last year also, he got the Mahapedicon oration of Dr. DB Orale, DB Shirole sir. So over to you, Deepa ma'am, for further proceedings. I welcome
Thank you.
again all the guests, all the EB members, Dr. Jitendra Gawane sir, and Dr. Manjusha Sherkar ma'am, and many Maha IP members, senior colleagues from these delegates. Over to you, Deepa ma'am.
Thank you, sir. Now I request our guest of honor, Dr. Khalatkar sir, to give his wishes to today's session.
Sir, unmute kara, sir, unmute kara. Please unmute, sir. Sir is traveling to Delhi, and sir's flight is at 10:15, so sir is in car. Sir, unmute kara.
Yes, sir. Just a minute. Come in.
Yes.
What happened? This I am actually doing. Just a minute. Please.
हाँ sir, start करा sir.
Sir, ऐकू येते sir.
ऐकू येतंय का?
हाँ sir, हाँ.
Hello. Yeah. So good evening. I'm on way to airport actually. So sorry, it may get disturbed. And really, it's a wonderful project and competition. There should be always competition. It's always there. If you go through competition, there is a results are always good. And I know there are two teams. One is like a rock, that is Raigad, and second is blessed with Maha Devi. So both team are equivalent, and you are all the experts. Dr. Mohite, known for his academic, nothing, only academic. And Dr. Pramod को हम ID का कीड़ा ही बोलते हैं. So these are the two experts, and definitely teams are good. I wish all the both team, and special my thanks to us, a really good event Maha AP is doing since last year. The credit goes to you all. Thank you once again. I wish all the best. This should be continue in all years. Thank you.
Thank you, sir. We welcome you for this session. I would just request you to pick up a sheet and to read out the name of the team who will be participating and
Okay.
facing the challenge for the first case.
Okay, these are two cheats. You saw these two cheats? Huh?
Yes. Yes.
So out of that one, I will put see
Team name.
team name, and this goes to with who are blessed with Amba Devi, that Kolhapur.
Okay, sir.
So
Okay.
the cheat
Thank you.
goes in favor of Kolhapur. Okay.
First place, yes.
Okay, sir. Thank you, sir.
Thank
Thank
you,
you very
Kolhapur.
much. In spite of your busy schedule, you have come to
No.
attend. the session.
It's my pride to have in Maha AP.
Thank you,
Right.
sir. Thank you.
Thank you.
Thank you, sir. So without wasting time, let's move to the first case. Today we have two dynamic presenters. Our first presenter is Dr. Sushruta Deshmukh. She's a pediatric consultant working in KM Hospital, Pune. And she's also been presently working as a treasurer, Pune IIP, and a treasurer for Pedicriticon. She will be presenting her first case. And our second presenter is Dr. Tushar Godbole, who is a pediatric and adolescent endocrinologist from Nashik. He's working as an associate professor at VP Medical College and also has written articles in IIP textbook of endocrinology. So now over to you, Dr. Sushruta Deshmukh, to present the case. You have 45 minutes. We are now at 9:20. So within 45 minutes, we'll be finishing off with the first case. And team Kolhapur, Dr. Uday Patil, sir, Dr. Mahesh Kore and Dr. Venkatesh Tarkaswan. Please keep your videos open and let's start with the case. Over to you, ma'am. Ma'am, please unmute yourself. Please unmute yourself, ma'am, and start sharing your screen.
Actually, somebody from IIP is going to share the
Yes,
screen.
yes, Neha.
Neha,
Please.
Neha, can you share the?
Yes, yes, she is doing. Yes.
So at the outset, I welcome the team Kolhapur, to which I will be presenting a case. And feel free to ask questions whenever you deem necessary, and I will try to answer to the best of my knowledge. So we can start the screen sharing now.
Yes.
Yes, so I would like the first slide, please. Yes, so am I audible?
Yes,
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 ma'am.
Yes.
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 Please start.
Yes. So we start, yeah, just let the entire screen come up, then I will. Yes. So to begin with, we have Daksh, where the suspense story will start unfolding. Daksh is a 6.5-month-old male infant. He was referred to and he was admitted with a senior pediatrician, and he was sent for ID consult and opinion. He came with the chief complaints of fever since the early days, since just after about his birth, irritability since his early days. He has cold and cough. He had recurrent respiratory infections, which began since he was 3 months old. And currently he is having a respiratory infection since the last 15 days. He has an altered voice since the last 15 days. And mother complains that he is less active and sleepy for 15 days. So a look towards a scientific fact that meticulous history and its systematic presentation will be actually enough to clinch a diagnosis in 85% of the cases. So appeal to you to have a detailed look at the history, and we will move ahead with the origin, duration, and progress. So the next slide, please. Yes, so the case continues with the origin, duration, and progress. He's 6.5-month-old baby who has fever since almost birth. He has almost three spikes every day on and off since birth to date. Mother complains that the child was irritable, and that has also been a more or less constant feature since birth, and it's a low grade sort of an irritability. He's alert, active, but throughout the day he's more or less cranky. He has a history of recurrent cold and cough, which has been back to back on and off, not requiring significant admissions, but yes, he has been admitted. I'll go ahead to it. Back to back since 3 months, and currently he has this fever since the last 15 days and respiratory infection for the last 3-4 days. He has presented with, this time he has been admitted again for fever. He has and as well as a cough, which has been dry, spasmodic, but has shown resolution over the last 1 week. His voice appears to be of low quality. He's a little dull, low activity, and more sleepy over the last 15 days, though feeding very well. So I would like to ask the contestants whether they have they have questions, or whether they want additional information from this history in particular.
Venkatesh, you want to ask something first?
Yes,
Hi,
sir.
Venkatesh. Are you there?
Yes. Yes, sir. Yes, sir.
Okay.
Yeah.
You can go ahead.
Yeah. Madam, can you just elaborate about the irritability?
Irritability is the child is alert and active, but the child it's just feeding well also. He's crying, he's conscious, alert and active. Just more cranky is what I would say by irritability.
Okay.
Anything? Uday, you want to
He's
ask?
he's feeding well, his activity is also normal, but he's just crying, irritable in between.
What is the fever intensity?
The
What is the-
fever has been moderate to high grade, roughly about 100.6 temperature. And it has been coming 3 times in a day, more or less. It is not associated with chills or rigors or not with rash.
Interfebrile period?
The interfebrile period also the child is irritable,
Irritable.
but not very dull or very sick.
Response to paracetamol?
It is responding to paracetamol partially, but not very good response to paracetamol.
Okay.
What's the milestone sugars?
I will like to ask much more, but with your this given history, what are my thoughts? I will just elaborate and then we'll go ahead. Because we'll come to birth history, we'll come to all this antenatal history, will come because it is started from day one of life. Okay. You said that fever since birth means day one of life. I presume that it is from day one of life. Fever is there.
The mother noticed that the child is warm and febrile maybe since the first week.
First week. Okay, we'll take it as a first week then. Okay, now he is 6.5 months old, and right from the early days of neonatal period, his fever is there. As fever is there, means inflammation is there. And inflammation can be an infective inflammation or non-infective inflammation. Okay, there are 2 ways.
Okay.
So anything which is infective will not go for such a long period, 6.5 months. So infection is less likely in this case. So we'll come to a non-infective inflammation in this case. Irritability suggests either a meningeal involvement, aseptic meningitis, or pain in a small baby. Pain can be there because of musculoskeletal involvement, or it can be because of aseptic meningitis itself. But as you have said, the child is conscious, means at that point of time, encephalopathy or encephalitis was not there. He had a recurrent cold and cough, which is very unusual for 3 months baby. Recurrent, that too recurrent. So whether we are dealing with immunodeficiency like disorder, that comes to my mind because lingering course right from the day first week of life and having a cough and cold, whether there was tachypnea, will come to that afterwards. And but low voice means larynx is affected, activity downs, and more sleepy means because of hypoxia he is having that encephalopathy or directly brain involvement. I don't know at this point of time, but we'll come to that afterwards. These are my thoughts with these 2 slides. We can go ahead.
He's just sleepy, very much arousable also.
Arousable. Yeah, but 6-month child sleepy means so many things will come. Probably maybe hypoxic, maybe tachypneic, maybe having encephalopathy, may not be having.
Okay. So I'd like to put your preliminary on inflammatory condition and infectious cause slightly lower down.
Lower down and more of an inflammatory disorder. And it can be a persistent within these 3 months of first 6 months of, it can be a structural disorder, it can be an immunological disorder, or it can be a functional disorder.
Okay. Should I move ahead?
Yeah.
Yes. Okay. Next slide, please. So just to narrow down the possibilities, sir, like as you rightly said, would you consider, how would you refute or how would you support the following conditions? As you said, infection, do you consider?
No, less likely. Less likely, very less. So systemic inflammatory disorders are more likely, that too coming on a very early age. So Kawasaki will not remain for such a long time. JI also not like, SLE monogenic can be there. Or more mild will favor nomad or Sinca type of disorders in this condition. Malignancy remaining for 6.5 months, less likely because it is lower on card.
Okay. Regarding infections, sir, would you like to consider some congenital infections or a chronic?
Yeah, that will be if you tell me the birth history.
Birth,
Yes,
we'll go with then birth history, then we'll decide whether it is congenital or not after that.
Okay, okay. And what about the other causes? Do you feel they could also contribute to it? Something like drug fever?
Hey, whether we have to confirm that whether he is febrile, because we presume that he was admitted and ID consultation was thought, means fever was documented.
Yes,
it was
he
not
has
50 CS.
Yes, he has a documented fever.
Yeah, he has a document. Endocrine central cause can be thought of, whether he was growing well, then you can think of central causes.
Okay, and what cause would you think of an endocrine or a central cause?
Like thyrotoxicosis. Thyrotoxicosis is less like, because we are not given something like this. Endocrine cause persist. So many no, ectodermal dysplasia can, but it will not present in such early age.
Okay, okay. So really very good inputs from you. So should we go ahead with the next slide?
Yes.
So I would like to go to the relevant history pertaining to this case. So Daksh is a product of second-degree consanguineous marriage. He's the second child. The first child is an elder daughter who's 5.5 years old, and she's been healthy. She's never been hospitalized or suffered from any chronic disorder. Regarding the ANC, the mother on the blood sonography as well as the sugar screening were absolutely normal. Incidentally, the mother was just operated in the second trimester for cervical cord compression, disc issues, and otherwise she was healthy. Mother also did not have any history of fever or rash or any drug consumption while she was carrying the baby. She has not also past history of recurrent miscarriages. Birth history, the baby's weight was 2.8 kg. That he cried immediately after birth, and he had an absolutely uneventful postnatal period. Mother started feeling that the child is warm after 7 or 8 days of life, but otherwise the child was not admitted during the postnatal period for any sort of infection. The child is exclusively breastfed since he's 6.5 months old. He has not been given any form of top feeding in the form of water, gutti, or anything. The child has been immunized under the Universal Immunization Program, has received BCG, all the 3 doses of Pentavac, 3 doses of Rotavac, as well as the 3 doses of oral polio vaccine. Next slide, please. Yes. So the child has just to summarize or just to briefly tell you, the child has had repeated consultations with recurrent history of fever. He has been hospitalized 3 times to date. The first one, the current one, is his 3rd admission. First, he was admitted at 4 months of age. For his fever, they just sought local consultations for which he was never admitted. But at 4 months of age, he was admitted for a minor fever, cold, cough. Second, again after 1 month, he was admitted. That time he was admitted for 7 days. Investigations were done and he was treated with antibiotics and IV fluids. The child was fine on day 4 or 5 and hence was discharged on day 7. Did not require invasive treatment while he was admitted. The child had, in the 2nd month, had oral thrush, for which he sought treatment from a local practitioner and he was okay. He never had history of breathlessness, rash, or any swellings in the body, any multiple vomiting episodes, or jaundice. The child passed clear urine, good volume, 9 to 10 times a day, and regular motions 3 per day, which were normal in consistency. Child feeds well, but child feeds every 1.5 hours. Every time over 5 to 10 minutes, and there is no sweating or breathlessness along with his breastfeeding episodes. He has no notable exposures. He has not come in contact with sick relatives, never received medicines for a long time, has never been operated, has no history of travel in 6 months, no exposure to animals, insects, or has not been given water, top milk, or food. So would you want any more information on this?
We'll go to first slide. Can you go to the first previous slide?
Yes, the previous one, please.
Previous slide, yeah.
Yeah.
Yes.
This was a second degree co-sign married to Mama directly.
Yes.
Consanguinity, yeah.
Atte Mame Bhavanda. Yes.
That becomes third degree then. Okay.
Sorry.
No problem.
Sorry, it was third degree. Yes. Sorry, sir.
Okay.
That is only in this.
Okay. Third degree co-sanguineous marriage. Co-sanguineous marriage is there. So
Okay.
all autosomal recessive disorders will come into our
Okay.
differential diagnosis. That
Okay.
inflammatory and non-infective and endocrine, all this will come.
Okay.
His birth weight was normal, 2.8, cried immediately, unimproved postnatal period, almost rules out any antenatal infection. Which congenital infections are almost ruled out. Okay,
Okay.
because he has grown well. Okay.
Okay.
So he has a fever in a first week or on 7th day, means
Yes.
something started after birth.
Yes.
Okay, this is my, and he has received BCG, UPV, Pentarota, and
Yes.
there are no adverse event with the BCG, means T cell immunity is good one. And if he's accepted OPV, Penta also, then probably we are not dealing with directly immunodeficiency disorder like that. Because if there is a SCID disorder, what we are maybe thinking of, BCG would have BCGiosis up till now, up to 6 months. So he has accepted that BCG well. That is a good indication that he has a T cell immunity is good one. OPV, his local immunity is also good one, gut immunity. Okay, he has not done very badly for that. And Penta, we have to test. We don't have any other clues for Penta. Okay, next.
So an excellent analysis, sir. And you generally from your analysis, you tend to be ruling out or in primary immunodeficiencies seem to be going down on your list,
Down.
right?
Yeah.
Yes.
Yeah.
Yes. Okay. So you have
And
ruled infections as well as primary immunodeficiency.
oral thrush was
Oral
there,
thrush,
and there was difficult to treat, or it was very much treatable.
Very much
easily
treatable.
treated.
Easily
Okay, but that is common in first infancy. It is common, so we should not worry
Yes.
about that. Without with antibiotic, it can come. But now I am worried about his good volume urine output. And every 1.5 hours he's feeding, means he is much more thirsty. And I want to know about how much is the volume of urine and how much he's feeding. That we want to know, because
good
and
breastfeeding.
what is now his right now, what is his birth weight and height?
Right now, wait.
Okay. Right now the child is 5.2 kgs. I will come to that slide later on.
Okay, no problem.
5.2 kgs. And urine output, mother just said that the child passes urine, 9 to 10 times a day with good volume. She was not using diapers, so it was a little bit difficult to quantitate the amount of urine.
Okay. But that is my concern. But
yeah, generally she felt that every time the child is feeding, the child is generally passing urine almost every time the child feeds.
And if on direct questioning, there are no direct evidence of dehydration in this baby.
On direct questioning, no. The
ape
child
was normal, eyes were not sunken like that.
Yes, it does.
Eyes were not sunken, ape was not sunken.
Sir, that will come in the clinical, the exam.
But on history also
mother is not there. Mother hasn't noticed something like that.
Okay, no problem there. The birth history is good, means congenital infections are ruled out. He has accepted BCG. Probably we are not dealing with immunodeficiency disorder, probably, but they can have sometimes. SCID can present, or BCG may not be, or it may not be effective like that also. Sometimes technical errors, then we are.
Okay, so now coming down to your best bet, what would your bets in order of priority?
Diagnosis.
Autoinflammatory disorders.
Okay.
That is first on card, because he's otherwise also 5.2 is not that bad. He's thriving, but the main problem is fever. So main problem is inflammation. And 6.5 months, right now was it no infective disorder will not either that will kill the baby, or that will spontaneously or remit itself. Okay, so only one thing remains is autoinflammatory disorders coming in a such early age, and second will be the PIDs, primary immunodeficiencies.
Okay, but that also you feel would be lower because he's
lower on the card. Yeah, but that should be kept.
Okay, okay. Would you like to even consider something like tuberculosis?
No, no,
No.
six.
Okay. Congenital
Six and a half
tuberculosis.
months. It is not fitting with the tuberculosis. By the end of 2 months,
Oh.
baby should be very much sicker or on a deathbed, or he should improve with treatment.
Okay. Yes. Great analysis to date. Let's move ahead. So I would like to give you details about his condition and investigations when he was admitted. So the first hospitalization was when Daksh was 3 months old. He had a hemoglobin of 11.5 with a WBC count of 14,500, neutrophils 27, lymphocytes 69, eosinophils 1, monocytes 3, platelets were adequate, 2.7 lakhs. And that time only one X-ray chest was done because he was admitted with fever and mild cough and coryza. But an X-ray test was done, which was normal. He was discharged after 3 or 4 days. Second, after a month, he was again hospitalized with the history of fever. That time his HB was 10.8 with a WBC count of 16,100. The differential being P30, lymphocytes 66, eosinophils 2, monocytes 2, platelets again adequate with 2.37. That time his urine investigation was done because of recurrent fever episodes, which again was normal. And a dengue workup was done. NS1 as well as IgM both were negative. And since he was admitted again a second time to rule out an immunodeficiency, HIV was done, which was negative. At that time, he was around 4.5 months to 5 months of age. The third admission, the next hemogram was again done since his fever did not subside in 2 or 3 days. A repeat hemogram was done, which showed an HB of 9.1 and more or less a TLC, WBC, platelets almost okay, good. A sugar was done 101, urea was 31, a thyroid stimulating hormone was done, which was 1.77, and ferritin was done in view of recurrent fever episodes to rule out an inflammatory condition, which ferritin showed 67. Further, he underwent a sonography, abdominal sonography to rule out a focus of infection, which turned out to be normal. An X-ray test again did not show anything specific, only just right hilar prominence with no shadows in the lungs. And a 2D echo was also done, probably to rule out inflammatory conditions, and 2D echo also was normal.
Venkatesh, you want to comment on this? First?
Yes, sir. Actually, I could see the drop in hemoglobin. In just 3 days, the hemoglobin has dropped by 1.7, sir.
Yes.
In his second admission.
Anything else you want to comment, Uday?
In the urine routine, what was the specific gravity? It was done?
Sir, it was not done.
Not done.
Sir, why are you thinking of specific gravity?
Diabetes insipidus can present
Diabetes
sometimes.
can present sometimes like this.
Okay.
With a
And what? Okay. So that was not done. It was just
First, on my comments on first CBC, HB is okay. This was done at 4 months, na? First admission is at 4 months.
Yes, 4 months.
Yeah, that is HB is good. 11.5 is good. Total count is good. This is lymphocytic 70%. That is goes with the age. That is normal. Means I was thinking if it is lymphopenia, I could thought of SCID one, but that is not there. And on a third CBC, eosinophil is 3%. Means we are not dealing with the infection. We are dealing with inflammatory condition probably. That is there. Slight reduction can be there in machine. I'm not 11.5 to 9.1 from 4 months to 6 months. Okay, no problem. Chest X-ray. I want to see the chest X-ray. If you could say that thymus is normal, I'm interested in thymus in this case.
Okay, sir. I don't have a chest X-ray to present, but thymus was normal.
thymus was
Normal.
Was
Okay.
tonsils.
Tonsils. They will come to examination.
In the examination, yes. So
ferritin is normal.
So this is the last, the third investigation. This is the last admission which was done when the child was 5.5 months old. During his third hospitalization, again he has a CBC of 10.5, WBC 15,300, Again, lymphocytes of 75, polymorphs of 20, and platelets are again adequate at 2.43. CRP was done in view of repeated infections, which was also normal, 0.2 milligrams per liter. He had an elevated ESR of 73. This time, an extensive workup was done to rule out systemic causes. Liver function tests were all normal. Renal function tests were also normal. His creatinine, blood urea was normal. However, electrolytes popped up showing sodium of more than 155, a potassium value of 4.94, and a chloride value of greater than 120 milliequivalents per liter. Since these electrolytes showed so high, we felt that whether a sample was taken from the hand in which an IV line was there with a DNS thing, rechecked, but they were found to be high. He was when he was referred that time, his IgG levels were also done, which were high. IgG was 904, IgA 289, which was high. However, IgM and IgE were normal. Again, an X-ray test and 2D echo was done, which was again normal.
Okay.
So your views now on this one?
Yeah. One minute.
ESR is high.
Yes.
ESR high and CRP normal means we are not dealing with autoinflammatory disorders, because
Okay.
CRP should be also high in autoinflammatory disorders. ESR high and CRP low or normal, we can think of only SLE, dermatomyositis, and sometimes Crohn's IBD like thing. But that is not. SLE will not present. Monogenic SLE can present, but it is also autoinflammatory or autoimmune disorder. Okay. But clues here are one. Sodium is high and chlorides are also high. So I want to know about ABG at the same point and urinary electrolytes at the same point. Because this is hypernatremia with hyperchloremia with normal potassium. Means it is not related to the RAS system. RAS system will have something different, maybe potassium and opposite direction.
Sir, but isn't potassium also on the higher side of normal?
No, 3.5 to 5.5 will be normal.
Yes,
4.5 is normal.
Potassium.
Okay.
No.
Okay, so then what do you
Venkatesh, will you like to say something? Because you are an intensive care man, hypernatremia, hyperchloremia. Okay, we like to interpret this with more than 155 means how much it was?
What was the
Actual
exact value?
Yeah, 160, sir.
60.
Is it maybe formula fed, madam?
Sorry?
Formula fed?
No, absolutely, completely
Absolutely breastfed.
Yes, totally breastfed.
Okay, hypernatremic. He was dehydrated at that point of time because IV line was there.
Yes, actually. I mean, that will be in the clinical features, but yes, since you asked me directly, yes, he was dehydrated.
Okay, so we'll go with hypernatremia. Causes of hypernatremia, we have to search for that. Okay, hyperchloremia will not give directly clue, but hyperchloremic metabolic acidosis is there, then it will give clue. But hypernatremia is a point by which we can go ahead for this hunt.
Great. Okay. And what would you think about the IG? What would you like to comment on the IgG and IgA, or you're okay?
IgA, I'm a general practitioner, madam. IgA levels, what are normal, I don't know. IgG levels, but we'll go with that. IgG high because he was infective, more of febrile condition. Can IgM normal, IgE normal? That okay. We'll keep in mind hyper IgM syndrome because IgM is normal. IgG, then we have to go for subset. Which are the subset which are high? Then we can think of that. But we'll go with that sodium now.
Yes, but you're not giving much weightage to the immunoglobulin levels because
we should give, but that lower than hypogammaglobulinemia, but they will not present right from the birth. Glutamine disease, hypogammaglobulinemia will not present right from the birth. They will have protection up to 6 months. 6 months after that they will have. So I'm not thinking of right now hypogammaglobulinemia conditions, and they are actually higher.
Perfect. Yes. So now again at the end of it, where would you place yourself? Where will you place your
hypernatremia.
best bet on? Okay.
Glucose was normal, na, madam?
Sorry?
Glucose was normal.
Glucose was normal. Yes, sir.
Okay, then we'll think of
Diabetes
endocrine
insipidus.
causes, AVP and all these things.
Okay.
And we'll hunt for that hypernatremia.
Central
That is
DI,
important.
does central DI present like this?
And diabetes insipidus will be the high incidence.
Yeah.
Central
Okay.
diabetes insipidus.
Yeah.
That's why specific gravity is
I
important.
must admit that the thinking and logic is fantastic. Okay, I move ahead to the next slide. So his anthropometry at 6.5 months, birth weight of 2.8. At present, he's 5.2 kgs. 5.5 months, he has almost doubled his weight. But there has been no much gain since the last 1 month. Head circumference 40.5, which is normal for age. Chest circumference 30. Head circumference is chest circumference 35 and mid upper arm circumference is 10 centimeters. So you're okay with this?
1 minute. Birth, okay, 2.8, okay.
Weight is okay. It is not altering.
Should be double,
Last one.
Slightly lesser. And he has lost weight actually. That is means everything started at the 4 months of age, I think. And 40 centimeters
is on lower side. It's around 42.
Yeah.
But maybe that he's just lost those 300 grams because in those 4.5 to 6.5 months, he was admitted thrice.
And that was seeker period. 4 to 6 months is the seeker period. Mid-arm circumference 10 is, but within these 6 months we cannot. But after 6 months this is very much less. We can have a SAM like this.
Yes. Okay, great. Should I move ahead?
Yeah.
Yes.
Okay. Going ahead to his general examination, he appeared thin for age. He was irritable, but he was easily consolable. He was responsive, and he had age-appropriate developmental milestones. There was no delay or no lag. He had mild dysmorphism features in the form of prominent ears, a bulbous nose, bushy eyebrows, and cyanophorus. On examination, there was no pallor, jaundice, lymphadenopathy, cyanosis, clubbing, focal tenderness. Skin, there was no evidence of rash or pigmentary changes. However, the turgor was reduced. Eyes were normal. Tongue was dry. Lips were parched. Otherwise, throat, ears were normal. Anterior fontanelle was just palpable. It was small. I mean, it was okay for his age. And his musculoskeletal system was normal, and genitals were also normal. So any comment on his general examination?
He seems to be dehydrated, madam.
Okay.
Probably having polyuria with hypernatremia.
Sir, why do you feel it could be polyuria?
But
Passing
there
lot of
there is
urine
no-
is dehydrated.
Yeah.
There is not obvious loss, but still there is no GI losses as per the history, and still the tongue is dry.
Okay. Okay.
And along with hypernatremia,
Right.
you are.
Yeah.
So, and you said that 9 to 10
9 to
times he
10
was
times.
passing urine. That
Yes.
point.
That point goes
For
in.
again polyuria and with hypernatremia, we are favoring probably central
Central
diabetes.
Diabetes insipidus.
Okay. You appear to be, I don't know, you appear to be going in in a good direction. Yes. So can I move ahead with the systemic examination?
Yeah.
Yes. So his vitals, again, his temperature was 100.4. Pulse was tachycardic. He was tachycardic with a pulse of 150 per minute. All peripheral pulsations were well felt, and he had a good capillary refill time, less than 3 seconds. He had a respiratory rate of 48 per minute. There was no distress. Blood pressure was 72 by 48 millimeters of mercury in the right upper arm. Capillary refill was 3 seconds, and saturation was 96% in room air. In CVS, other than tachycardia, he had no murmurs. Sounds were audible, well audible. Chest, there was mild tachypnea. However, there were no retractions, no adventitious sounds. Air entry was bilaterally equal and normal. And just he had a little nose block, so they were conducted upper airway sounds. Abdomen soft, liver was just 1 centimeter, palpable, non-tender. Spleen and kidneys were normal. CNS was also normal. So keen physical examination would just, I believe, add 10% to the diagnostic yield. History would be 85%. And your logical analysis with examination being credited to just 10%. So you require any other information or any more questions on my side?
Yeah, how he responded to your IV lineup, whether the hypernatremia was temporary or persistent, and his urine output now. We want to measure that urine output. How was it? If it is more than 4 ml per kg per hour, then it is significantly polyuric. And then we should think of causes of polyuria with hypernatremia. Most likely a central cause, central diabetes insipidus. And then we have to find out the cause for that central diabetes insipidus, whether there is craniopharyngioma or some tumor or some glioma, because he has sustained for these 6.5 months.
Okay. So he was, after receiving his IV drip, he was better and his irritability reduced. Fever also went down and urine output was always good.
Yeah.
So
with
by
dehydration
adding-
also it was good, means he was polyuric actually.
Okay.
We want now ABGs for this.
Well, unfortunately, since patient was referred from outside at that time, we don't have the ABG reports with us.
Okay. So, all why he was polyuric, that can be a central or nephrogenic.
Yeah.
But in this case, you said that there was no sweating. That is also clue that he was almost dehydrated continuously.
Okay.
There was no sweating in your history. That he was not sweating.
Okay.
Okay. Anything now? He was tachycardic.
Mild tachypnea was there.
And without any inflammatory or without any localizing signs to any system like RAS, CVS or abdomen. He has not looked. It was generalized then. And with temperature of 100, 150 again tachycardic for that. Means he was dehydrated. And dry tongue will also favor that dehydration. AF was normal or A was shrunken?
AF was sunken.
Shrunken. That also tells that he was dehydrated. Then we have to find out the cause of dehydration, whether he was not vomiting or he was not losing from GI. He was losing through the kidneys only. So kidneys are called, or he is a boy, no?
Yes.
Yeah, boy.
Yeah. Then it can be both nephrogenic diabetes or central diabetes.
Okay, but for nephrogenic,
X-linked recessive, so it has to be central. Nephrogenic is X-linked recessive.
nephrogenic, but he had his normal renal functions. Would you still want to consider?
Yeah. Yes. It can be normal. Yeah.
Okay.
It is not CKD. Okay. It is nephrogenic diabetes insipidus.
Okay, great. Okay. So can I move ahead?
Yeah.
Next slide, please. Okay, so would you like to hospitalize the child? What investigations you want? Whether you want any special investigations and references or consultations. So any specific investigation which
we want to hospitalize for two purposes.
Okay.
Whether he is actually polyuric, that first we have to calculate the urine output directly. And if it's more than 4 ml per kg per hour, it is polyuric. And then you will find out the cause for that polyuria. Either he is losing through the kidney because of kidney problem, or he is losing because of absence of antidiuretic hormone.
Central problem.
Okay.
Okay,
or
but
anything else, because glucose is normal.
Okay. If he was wasting because of kidney issues, then wouldn't he have failure to thrive or something? I'm just asking you this.
Yeah. That it is less on card, but we have to keep wide open. Okay. And investigation in terms of, we like to do all electrolytes again with ABG, with urinary electrolytes,
specific gravity,
everything.
Great. So in special investigations, you wanted a urine osmolality and a
urine osmolality will like.
Okay. And any other investigations you will want to do?
Then if we're pointing towards CNS, we'll go for a MRI.
Okay. And you would like to refer or consult anybody?
Pediatric endocrinologist.
Okay. Okay. So can I have the next slide, please? Okay, so yeah, just let's go to the previous one. Just let's go to the previous one. Yes, so now what would be your best bet? And then I would open up the investigation which specifically you asked for. I mean, you're almost there.
It is central diabetes insipidus.
So absolutely fantastic. I will just corroborate it with the investigations. Sir, मैं नमस्कार करते तुम्हाला.
आम्ही पण
Next
तुम्हाला
case.
करतो.
So the next slide. Yeah, the next slide. So as you rightly said, a urine osmolality was done, which showed a very dilute urine of 94.4 milliosmoles per kg, and which was again a pointer towards a diabetes insipidus. With the next slide, please. Yeah, with a simultaneously serum osmolality, which was
More
very
than
high.
300. Yeah,
More than 300, yes, 300 milliosmoles per kg. So a dilute urine with a high serum osmolality would point towards a diabetes insipidus, as you rightly went right, not to the group, you directly went to the, you hit the nail. The next slide, please. This is again the same investigations which I showed, only like the last one, which always shows hypernatremia in all the three things. And probably the last one was okay because the fluids were administered to the child and this dehydration decreased to some extent. The next one, please. Next slide, please. Yes, so like you rightly said, infectious, rheumatological, the heads which you discussed were infectious, rheumatological, oncological, others, and idiopathic. And well, this one fell into the others, which were the rare 5%. We ruled out the different infections according to your analysis, as well as the rheumatological conditions because of the ESR and CRP. Oncology, like as you rightly said, till 6 months without any other specific local manifestation or systemic manifestation of the child becoming sick, we ruled out an oncology. In the others, we also ruled out infectious diseases for the vaccine receipt, and endocrine you always kept higher on the cards. So it actually fell into the 5% endocrine category with a diabetes insipidus as the right diagnosis, which you arrived at. So the next case. So in brief, diabetes insipidus would clinically present as polyuria with dipsia, either due to ADH deficiency central or unresponsiveness as nephrogenic. The DD of polyuria and polydipsia will be central, nephrogenic causes, or diabetes mellitus. Here, polyuria and polydipsia. So central would be genetic, acquired as in trauma or surgery. Neoplasms, as you rightly said, was craniopharyngioma or germinomas, which could be very small, but compressing on the posterior pituitary or the hypothalamic stalk going to the posterior pituitary. Infiltrative, like a Langerhans cell histiocytosis or idiopathic. Nephrogenic as autosomal recessive or dominant, not necessarily a kidney disease, as you rightly said, and one of the causes is kidney disease, and diabetes, which was ruled out because his sugars were normal. The next one, next and last line. Clinical features in diabetes insipidus would be irritability, failure to thrive, and intermittent fever, just like Daksh presented with. History, as you again rightly asked, you wanted a specific fluid input and output, and you wanted a voiding pattern, which I could not provide. Nocturia and enuresis would not be applicable to this child. Physical examination, he was to look at the hydration status where he was dehydrated. He didn't have visual or CNS dysfunction, and other pituitary deficiencies also would be associated, but this child did not have them. So the diagnosis was claimed with serum osmolality of greater than 300 and a urine osmolality less than 300 milliosmoles per kg with hypernatremia. And what investigations would be required, as you rightly said, were serum osmolality, urine specific gravity, and the others like a repetition of electrolytes, creatinine, glucose, and calcium. So I thank you for a wonderful participation. The next slide, please. So I thank you for a wonderful participation, and I would like to hand over to the experts.
Thank you, ma'am. And wow, what a presentation. And of course, it's always a pleasure to hear Kore sir, the way he dissects every case, and we call him Sherlock Holmes because he just simplifies all the complicated things. Now I can see here Mohite sir must be ready with his notes. So I request our expert, Dr. Mohite, to give his comments on this case.
Honestly, as you rightly said, first of all, congratulations and great compliments to the presenter, Dr. Sushruta. Wonderful case. and so nicely worked up. Though maybe we'll discuss few points at the end, what perhaps more could be done. And when Mahesh and his team is there, I don't have many comments to add to that. The way he dissected, amazing. Mahesh has always got that knack of going into detail of the case. So whenever he is there, it's always pleasure to listen to him. I was just wondering, Mahesh is more expert in this field than me of auto-inflammatory disorders. So whether, I don't know, auto-inflammatory, whether Mahesh, you can see right from the first week of life?
Yeah, right from the birth.
Yeah, so
Right from
that's
the birth,
something.
right from
Yeah.
the intrauterine drive. Because Akadi Gotyar is an interferonopathy which presents like a torch infection. And I had a case of Akadi Gotyar in my armamentarium, and she presented like rash right from the beginning, has a small head, and on CT we had a calcification. It is called as a Akadi has called them as a pseudo torch presentation, a torch like presentation, but there is no infection as such in that. So Akadi Gotyar can present intranatally because interferonopathy will present starts from the ANC period only. So all autoimmune disorder can present right from the birth.
Right.
But they will
So-
have
so
some
that-
clues like pustular psoriasis rash or rash of interferonopathy right from the beginning, or conjunctivitis. I was madam has said once conjunctivitis, redness of eyes was there. Then I thought that I am dealing with autoimmune disorder, but it was only transient. Then and CRP should be high in all autoimmune disorders. CRP and ESR, and that was the clue. CRP was down 0.5 only, and ESR. So it was not fitting into autoinflammatory disorder. So we have to think of other causes.
Then again, the immunodeficiency presenting only with fever without any localizing or non-localizing
Yeah,
markers.
that's
is a
why
bit unusual.
we kept this on a lower card.
Going on for 6 months
Yeah,
without
6
any
months.
specific system
Yeah.
failure is an unusual thing. There
Unusual.
was definitely poor weight gain in this child.
Yeah.
And she incidentally mentioned that passing frequently, but 9 to 10 times, which can be normal in any baby. But again, the measurement of that urine, when the child comes to that extent after 5 or 6 months, perhaps with a frequent passage of urine, you will definitely say. Perhaps the major clue was sodium hypernatremia.
Yeah, yeah.
155
That
with
was a clue.
chloride.
That was a clue
That's
in
where
this
we
case.
started thinking. But one clue she perhaps gave prior to that was urea was 31. So it was more like a pre-renal affection. In spite of normal lactic KFT, the urea was slightly on the higher side with polyuria with a dehydration
But
findings.
madam
So
has
that
not
could,
mentioned
and this is something
BUN
which
or
is
blood
not
urea.
obvious loss.
BUN
He
will
said
be
mentioned
a
urea.
range of 20 usually higher. Blood urea up to 40 will be normal. So I thought that it is blood urea which is up to 40.
Yeah, but then that could have been elaborated at that point, which
yeah.
could have taken, and that she gave in second or third slide only. So maybe I understand that whole conglomeration of kind of findings. I'm talking in retrospect. What you did is perhaps one of the best kind of elaboration. But barring that, everything was absolutely all right. And I think Uday also asked about the urine specific gravity upfront. So once you are having a polyuric child with a poor weight gain, with the urea going up with hypernatremia, next thing obviously comes is definitely comes is urine specific gravity. So if you're having that disparity of low urine specific gravity with high plasma osmolality, I think you have almost made a diagnosis. And then the question comes with nephrogenic or central, which you already said. Now, once it is central, have you investigated further? I saw the question from Dr. Naresh Tayade in the chat box. So have you? I think definitely MRI to banta hi hai, like LCH, but there are no markers of LCH in this child apart from this central affection, because NCH would have given with some skin markers or some
skin
respiratory markers or organomegaly. So all those things were missing in this child. So whether you have such just primary, central, and she's autosomal recessive, consanguinity is there. So kind of a genetic variant, and maybe some genetic testing will be desirable in this child. But I actually I was just wondering how many odd cases we have seen or heard over last almost 2 years, and every new case has given you a new flavor. Hardly any case has been repeated in last 1.5 years, and still almost 90% cases are cracked in this forum. That's a beauty. Believe me, in last 1.5 year, 2 years, we have picked up at least 7 or 8 new faculty from this forum. Those were really talented youngsters, talented pediatricians working in the field. And I'm really amazed to see the success of this whole story. And Mahesh is far beyond, far above the talent story. So thank you, Mahesh. It was absolutely wonderful kind of a dissection of a case. I'm sure had Dr. Ambedkar been here, he would have given you a great compliment, because this is a success of this whole session, the way the case has been taken. Thank you very much.
Thank you, sir. Now
I
request
personally,
Dr.
1 minute, ma'am.
In short, in short, you can give your comments, sir. We'll have to
I,
go to
1 minute, sir. 1 minute. I personally call Ambedkar, sir, but because he had a guest from outside, out of India, he couldn't join today.
Okay.
Thank you.
May I talk?
Yes, sir. Nanudekar, sir.
Narendra, please.
Yeah, excellent. With Mahesh around, we knew the focus will be right from the history, and he has correctly dissected the case as whether it was infective or not infective. It was not infective, was well seen right from the beginning. Only one question which I wanted to ask: why did we talk about the history first and jump to the investigations without the physical examination? Because usually when we talk, we present our cases to Ambedkar sir, he says the diagnosis is done on the history and examination is there to you look for specific things. Now, a child who is irritable, child who is running mild fever and definitely not infective. If this child was seen clinical examination with mild dehydration with a slightly dewy feel, that itself would have led us to the clinical finding that this child is probably having hypernatremic dehydration. And with hypernatremic dehydration, then you go back again to the history of whether this child was passing excessive amount of urine, which is out of proportion to what his age would indicate. And that itself would have given us clue clinically on examination itself. Plus, addition to that, the way failure to thrive, because he has definitely shown a drop of weight. And then, of course, even if we were to go in this way, Mahesh would have cracked it on clinical examination. This child probably looks hypernatremic dehydration with the child who is irritable and running fever. Probably we are dealing with some kind of diabetes insipidus. And again, with a male child, so X-linked chances are very high. That would be my way of thinking. And of course, we will always think of PIDs also, but the fact that the counts were normal all throughout and the child has otherwise not failed all that badly would have taken us away from the PID. And of course, the chances of autoinflammatory disorders were there. But with this history of fever with dehydration would have probably led to us to a diagnosis of diabetes insipidus. And of course, with a clinical examination coming in between. Thanks. That's all from my side.
Thank you, sir. Thank you, Sushruta ma'am and the Kolhapur team. And now let's start with the second case now. I hand over to Dr. Trupti Mahatme for conducting the next case. Over to you, Dr. Trupti.
Yeah, thank you, Dr. Deepa. Hello, everyone. So let's begin with the second case. And for the second case, we have a presenter, Dr. Tushar Godbole, who I think doesn't need any introduction. He's a pediatric and adolescent endocrinologist from Nasik. He's director of Harmony Health Hub. And he's also associate professor of Dr. Vasantrao Pawar Medical College and Hospital Nashik. He has many feathers in his cap, including he has written book chapters in GAI's textbooks of pediatric, IIP textbooks of endocrinology, and also PG textbooks of pediatrics. And he has many national and international publications. So welcome, Dr. Tushar Godbole. I would also like to invite team members of Team Raigad, Dr. Sunil Seth, Dr. Abasai Patankar sir, and Dr. Rajendra Chandorkar sir. So welcome team members and the presenter. I would like to hand over the session to Dr. Tushar Godbole.
Thank you, Dr. Trupti, and welcome, welcome team. Welcome, Dr. Abasai, Dr. Rajendra sir, and Dr. Sunil. So at the onset, let me apologize for multiple things. First is joining in late. It was indeed a very interesting case previously. I could hear it halfway through, and I could make that the discussion is going towards DI, but I purposefully did not intervene. Wonderful case. So let's go to the next part of the session, and I'll quickly share my screen. I hope you all can see my screen in full screen mode.
Yes, yes.
Yep. So this is this was a very last moment request, and I hope I fulfill the requirements. Thank you, Dr. Amol sir, for putting in my name, although it was very at last moment, but I'll try and make good use of the time that we have. So I'm presenting a case who is 8-month-old male child who is apparently well, who was apparently well until 6 months of age, thriving apparently well, development was age appropriate as per the mother. And he's suddenly admitted at 8 months of age with poor feeding that was noticed 3 days ago, vomiting over last 2 days, and fast breathing noticed since last 1 day. Negative history, there is no history of any documented fever. Pardon me, that vomiting should be read as loose motion. So no loose motions, no skin lesions, no convulsions. The child is predominantly breastfed, 8-month-old male child, and receives 2 to 3 complementary feeds per day. And development seems to be age appropriate. So this is just the brief history for 3 days. So what are your comments?
It's an acute event. There is no chronicity in this case.
So what system do you think we are dealing with? Just broad category. Does it seem infective or?
See, there is no non-infective. Yes, Sunil.
There is no history of fever, and just with the poor feeding, vomiting, and fast breathing. So infection is out. So it has to be some kind of either non-infective pathology. If you consider a poor feeding and vomiting with fast breathing, it could be attributed. There is no cough, there is no cold. So it could be attributed to any metabolic acidosis where the baby is having the fast breathing and vomiting. So we would like to know in detail about the history, like how many days the poor feeding is there, like is there any history of any illness in the past?
Yeah, so I'll go to the previous past history and the birth history as well. So the child is born out of second degree consanguineous union. So it's a second issue of distant consanguineous union. The antenatal care was uneventful. There was no polyhydramnios or oligohydramnios or any significant events in the ANC. It was a term delivery. Birth weight was 3 kilograms. The child was admitted in NICU for respiratory distress syndrome transiently. But then during that episode, the baby developed anemia and was transfused. So one blood transfusion was given, and then subsequently the child went home. So any more specific history you need? So there is one history of blood transfusion in the neonatal age group, and for last 8 months, apparently the child has been well, and now this acute history of poor feeding, vomiting, and fast breathing.
No, it's okay. You can continue.
Okay. So would you like to ask anything about the fast breathing, in history, since
that history needs to be dissected, because fast breathing, whether it's acutely or respiratory distress.
So on history.
So fast breathing, we would like to know that, since it's basically, to be very frank with you, endocrinology. So when the symptom comes, we always go in that direction, whether we are dealing with diabetes, basically, or not. We jump on that, definitely is not going to be justification. So we just like to know, breathing, respiratory distress, or just a tachypnea.
Right. So on history, there was no obvious, grunting voice or any retractions noticed by the mother. It is plain simple, fast breathing that the mother has noticed. And if you were to ask about, any specific history, since you know that, since you know that, fast breathing is happening and I'm presenting, so would you like to ask any specific history?
It definitely favors a metabolic problem, and acidotic breathing points towards a metabolic problem. So either some.
So there is history of excessive wet diapers noticed by the mother over last couple of months, and the baby also suffers off and on with a diaper rash. So that is a very positive history. After asking, the mother has told, of course. So now, does it add any value? I think Dr. Abbas had already hinted that he is thinking towards diabetes as one of the causes. So what do you think now?
It's a case of basically polyuria. Excessively wet diapers must be patient passing large quantity or more frequent urine, which has led to even diaper rash. So it is a significant history which leads to taken in account.
Perfect. So should we go ahead?
Yes, sir.
Yeah. So possibilities at the end of the history. So we are dealing with an infant with gradual onset illness with sudden decompensation. There is anemia, respiratory distress. The child looks distressed. Excessive urination, urinary infection is one of the possibilities, and the child is born of second degree consanguinity. So moving on to examination findings. The child is conscious but drowsy, and the child is indeed pale looking. The child is dehydrated with sunken eyes. There is Kussmaul's breathing present, so deep rapid breathing is there. Heart rate is 150, respiratory rate is 48 per minute, and there are vesicular sounds, no adventitious sounds, no rhonchi, no crepitations. Per abdomen soft with 2 centimeters of liver palpable. So what are, and there is soft systolic murmur probably due to the paleness or pallor. So what are your thoughts now?
Definitely there is a metabolic acidosis which is there, and that is why the baby is breathless right now.
Yeah.
And there is no any respiratory pathology as such.
Correct. So the chest seems fine. So this is probably metabolic.
And along with that, there is a pallor. So that we have to look into, because that leads to the systolic murmur.
Absolutely. So I'll also give
diabetic ketoacidosis with push down liver due to tachypnea.
Correct. So we have a possibility of diabetic ketoacidosis. That's correct, because there is a history of excessive urination, and yes. Do you, any one of you is thinking in terms of any other diabetes other than diabetes mellitus?
Already, the previous case, diabetes insipidus. Diabetes insipidus not cause breathing or the metabolic acidosis type of presentation. So to be on this case, we take care of a metabolic acidosis and the cause of that hyperglycemia or whatever.
So any other cause can you think of that can come with?
The way is anemia at the neonatal period, which has been transfused, and this presentation also pallor. These two things needs to be basically one thought.
So can you do you think of any other cause, other than decay, that can come in neonatal or infantile period with tachypnea and acidosis?
Any metabolic disorder, metabolic acidosis disorders, basically can talk.
Yeah. So do you wish to ask any pertaining history or any examination finding at this stage? So this is the anthropometry. Length is 67 centimeters, 25th percentile. Weight is around 7.7 kilos, between 3rd and 25th percentile. And head circumference is below 3rd percentile, 41.2 centimeters. So shall I wait for the anthropometry? You want?
It's a well-grown child with head circumference of the lesser side. So it's a more of a microcephaly. Weight and length is normal, appropriate for the age.
Correct.
Child is failing to thrive, though it is acute presentation. It points towards a chronic underlying problem.
Absolutely. So thoughts at the end of examination: we have a sick child with dehydration, respiratory distress, anemia with a clear chest. So what all things come to your mind?
What is the severity of anemia?
So the child is visibly pale with tachypnea. I would say, in a while I'm going to give you the hemoglobin value, but it's moderate to severe pallor. Yeah, it's not some pallor, it's severe pallor on examination. Yeah. Although the child is dehydrated, still the child is looking pale. Because normally in dehydrated children we have hemo concentration, but yet the child is looking pale.
So
shall we go ahead?
Yeah, yes, please.
Yeah. So thinking in terms of all these possibilities of metabolic diabetic ketoacidosis and the other things, what labs would you like to order?
CBC.
Let's start with the CBC. Right. So the CBC is hemoglobin of 7 gram% with mild leukocytosis and neutrophilia. So predominantly neutrophils are present. The CRP has turned out to be negative. The electrolytes are sodium of 126, potassium 3.7 with a calcium of 8.9, low normal. And chest X-ray is showing clear lung field. So clearly it is not, pneumonia.
Sugar and urine.
Right. So you need, Rajendra sir needs
blood sugar and urine for ketones and urine. Blood sugar and urine.
Perfect. So first blood sugar is 600 milligram%. So we have diabetes or at least hyperglycemia. The HbA1c has come down to be 11.2%. So does it?
Yes, it is very significant. It's very high.
Urine ketones, Rajendra sir asked 3 plus.
Confirms.
Anything? So anything else you need?
Serum osmolarity.
Serum osmolarity, unfortunately, it was not done. Yeah, but how will it help? Because we have already sugar that is quite high. So we would first treat the sugar and then probably think of any comorbidities. So at this stage, of course, the priority will be to stabilize the patient because the patient is coming to us with respiratory distress, with ketosis, probably acidosis. So we will also ask for a VBG, venous blood gas, and that is showing severe metabolic acidosis of pH of 7.1 with bicarb of 7.4. So we have a diagnosis of diabetic ketoacidosis in an 8-month-old baby along with severe pallor. So any other things you want to order?
USG album.
Yeah. So USG was done subsequently and it was normal. There was no pancreatic abnormalities. But at this stage, we just ordered one C peptide to look for any, the child's own insulin secretion, and it was the insulin was detectable. The C peptide was detectable. So at this stage, we have a diagnosis of newly detected diabetes and with an onset below 6 months that makes this to be neonatal diabetes with anemia and severe diabetic ketoacidosis. So how should we go ahead with this now? We are yet far away from the diagnosis. This is just
to have blood indices to look
perfect.
at the
Absolutely. So since the child is severely dehydrated, we will manage the child with insulin. So we started him on IV insulin fluids, stabilized over next 48 hours, and then switched him over to subcutaneous insulin with a glargine of 2 units in the morning and a aspart insulin of 1 unit only if the sugar was above 120, because the child is extremely small and we are very, very afraid of hypoglycemias in infants. So to begin with, we keep them very safe. We just start with basal insulin and we take it very slowly depending on the sugar readings. But the sugar readings were not controlled for a 7 kg child on 5 to 7 units of insulin per day. It was not controlled. So we had to escalate the insulin to 5 units of glargine and 2 and 1 unit of aspart. So the child has got slightly higher insulin requirements than what you normally expect. And since the child is frequently breastfeeding, it's very difficult to give those many boluses. So we accepted some degree of hyperglycemia and we just pulled him out of that decay, and then we evaluated him for the anemia. We counseled him for the SMBG, that is the self-monitoring of blood glucose. Now, anything else that has to be done at this stage? For the diabetes part, what would you like to consider?
Microencephaly and anemia needs to be addressed, whether they have got any contribution to the per se diabetes.
Absolutely. Yes, that is correct. And with regards to neonatal diabetes, what is the next step after starting insulin? Since we know that HbA1c was quite high in an 8-month-old, and HbA1c depicts the sugar control over last 3 months, meaning that the onset was below 6 months of age. That qualifies for neonatal diabetes. So what investigation would you want to do for the neonatal diabetes part? The ultrasound, as Rajendra sir has ordered, is normal. So we have no pancreatic or renal anomalies, no cyst in the kidneys or liver. So would you like to order any genetic test? Because there is second degree consanguineous union along with a neonatal variety of diabetes. So we went ahead and sent the sample to Exeter lab, which provides free of cost screening. Since the child comes from the resource limited setting, we did not send it to any commercial labs, but rather we sent it to the Exeter lab at UK, which are providing this mutation studies free of cost. So they performed the KCNJ11 and insulin gene mutation that are the most common varieties of neonatal diabetes, and they have come down to be normal. So as of now, we have an unknown variety of neonatal diabetes, and at the same time, we also have anemia. So now I'll go further. The child was sent home on insulin. The child went home and suffered again with couple of episodes of pneumonia. And this time the pneumonia happened at 10 months of age and 13 months of age. Here the child was at the native place. And again, the child developed into anemia and received blood transfusion. Sugars were acceptable during these admissions, so the child did not go into decay, and it was a purely admission related to anemia and requiring blood transfusion. So in 13 months of life, the child received 4 blood transfusions. Right. So what do you think could be the cause of the anemia, and what workup would you want to perform in this case?
What were the blood indices before giving blood transfusion?
Yeah. So so we did not have the indices prior to the blood transfusion. So we actually waited for a couple of months after the last blood transfusion, and then as I saw the child, I got his CBC and indices done. So this is the indices. These are the indices. Hemoglobin of 6.7, mean corpuscular volume of 90, with MCH of 31.5. Platelets were low normal, and now HbA1c has come down from 11% to 9.9%, and the child is still requiring slightly above normal requirements of insulin.
MCV is bit high.
Yeah.
So MCV is high, patient is getting current maybe hemolysis, which is causing patient to undergo transfusions. So maybe anemia can be thought at this time. Don't know, but jaundice is not there.
Yeah. So any more tests you need for anemia workup?
Yes. Bone marrow studies.
Before bone marrow, any simpler tests would you want to consider?
HB electrophoresis.
Absolutely. So HB electrophoresis was done. That was normal. Ferritin levels, the iron studies were normal. B12 was also normal. Unfortunately, we don't have folic acid values here, but B12 was normal, and the corrected retic count is also normal. So if you want to rule out the common causes of macrocytic anemia, we thought of all these possibilities, and they all came back to be normal. So we were we had no clue about the anemia at this stage. All we know that the child requires blood transfusion and the child has diabetes. So we went ahead, and at 15 months of age, after 2 months of the last blood transfusion, I saw the child in my OPD, and again the anemia was alarming. The hemoglobin again dropped down to 6.7. Iron studies, B12, electrophoresis was done already, that was normal. On inquiry now, at 15 months of age, the child now exhibits speech delay, which was not evident in the previous visits. Now the child, we only had microcephaly, but now the child also has speech delay. Of course, no epilepsy or no convulsions, but only speech delay. And now there is a new onset nystagmus that has come. And anemia is not improving to iron, folic acid, and B12 supplementation. So the peripheral picture is showing macrocytic or megaloblastic, not exactly megaloblastic, but macrocytic picture. There were no segmented neutrophils, but the MCV was on a higher side. So hearing test was ordered for the speech delay, and the hearing test actually is pending until next slide. Meanwhile, would you like to give your comments?
Why was specifically hearing test was done?
So for the speech delays.
Okay.
Yeah. So we have neonatal diabetes, speech delay, and refractory anemia of non-nutritional origin. So any thoughts?
Here we have to intervene with bone marrow studies.
Syndrome child, but don't know which syndrome exactly to hit.
Absolutely. So bone. I was also perplexed with this case. I had absolutely no clue, and I was thinking of going ahead with bone marrow, but again, the patient had issues. The patient stays in a remote place, and they were, contemplating whether we should come to, the hematology center for bone marrow. But meanwhile, we got the hearing test done, and to my surprise, this was the hearing test, the assessment, otoacoustic emission, OAE, and both of them were refer. And we went ahead with a BERA also later on, and the BERA has shown us severe bilateral sensory neural deafness. So now, what are your thoughts?
Definitely must be a something which is common, maybe a guy, but we are not clear. At least I am not able to.
Hello.
Hello. Yes, it was.
Thiamine responsive megaloblastic anemia.
We'll have to, let's see what fits it in, what it fits into. So we have neonatal diabetes with iron, refractory anemia, and sensory neural hearing loss. So we did not know the cause. So something struck my mind, and I asked the people from Exeter lab. I wrote an email and asked them to evaluate for a certain gene, and I started the child on a tablet. I'll not reveal the name of the tablet. And after starting this tablet, the nystagmus improved in 1 month. The child is still on insulin, but the requirements dropped down drastically. The sugar started to become better on the tablet, and hemoglobin improved. And the child who was not improving with the all the supplements, including iron, B12, folic acid, etc. After starting this tablet, the hemoglobin magically improved, and no further blood transfusions were required.
That was a wonder tablet. Yeah.
So this is the response to that tablet. So before tablet and after tablet, you can see the CBC.
Yes.
Look at the MCV.
Yeah, no.
So what tablet are we talking about? And what is the diagnosis? So what is the diagnosis?
Yes,
I think Dr. Vipul has already mentioned, I think.
Yes.
Yeah. So of course, this is a very, very intriguing case. It took me almost more than 6 months to arrive at a diagnosis, but I thought this is a good case to highlight, various aspects of neonatal diabetes as well as anemia. And sometimes we have to think out of the box. So this was indeed the mutation analysis of the same patient, where it showed a homozygous mutation in the SLC19A2 gene, and this is indeed thiamine responsive megaloblastic anemia. TRMA with 3 components as megaloblastic anemia that does not respond to B12 folic acid but responds to 50 to 100 milligrams of thiamine. We have sensory neural deafness that is progressive, may start early, often congenital, and that was giving rise to the speech delay. And we have diabetes mellitus, which is non-autoimmune. Onset could be infancy to adolescence, and C-peptide are preserved but on a deficient side. So this is all from my side. So we put this child on thiamine. The child is still on insulin. So this is called as Rogers syndrome, thiamine responsive megaloblastic anemia. We have so far 4 or 5 cases, typically between 1.5 years to 10 years. Mine is the youngest one. I'm still to report, but this is probably the youngest one from the Indian context. Thank you. Thank you.
Great. Excellent.
Thank you. Thank you so much, Dr. Tushar. Very, very interesting and tricky case, and very well contributed by all the team members. And probably the initial diagnosis is very much clear on the first slide itself, because one of the greatest clue, as sir said, was the presenter is a pediatric endocrinologist. But yes, it was very tricky. I would like to invite both the experts, Dr. Mahesh Mohite sir and Dr. Nani Madekar sir, for their expert comments. Dr. Mahesh Mohite sir, please.
It was actually multiple specialities brought into one particular case. Wonderful case, no doubt, but not so common.
Yeah,
as you said, only 4 or 5 cases reported.
I agree.
So at the general pediatrician's level, perhaps it was a bit too high. I'm sure very few of us guessed it well in front, maybe at the last with all the conglomeration of things. And Vipul is brilliant, no doubt. He just came out with a wonderful diagnosis, no doubt about it. But as I said, Red, I was just wondering why this child had anemia and full-term baby developing respiratory distress upfront. The full-term baby developing, I wanted to know at what age. Was he immediately transferred to NICU for respiratory distress, or he developed after some time?
Unfortunately, we don't have the reports. He was admitted at civil hospital. There was only one discharge.
But on the history, we could have got it that which day he was hospitalized. Was he immediately shifted, or he received it after 3 or 4 days? Okay.
So it was
he required transfusion upfront at birth.
No.
So the whole problem started right at birth. There is no reason otherwise a full-term baby with respiratory distress. I was wondering whether it's some kind of a severe hemolysis which led to cardiac failure there itself. And again, at 8 or 9 months, he had similar episode. So what is this condition which is causing recurrent hemolysis? That was my first guess. Then he came with recurrent respiratory problems twice. So respiratory problem with anemia, I was wondering whether it is a hemosiderosis, idiopathic hemosiderosis. That can start around that age, but there the early neonatal age group was missing. And then you came out with a probable megaloblastic, though 90 is not really a big number, but with that you had a severe RDW high. So that was definitely indicating of some erythrocytosis. And so obviously there was some kind of a nutritional deficiency anemia, and that is how it was taking to megaloblastic anemia. But a combination of all these three culminating into thiamine was definitely a very wonderful guess by people. Compliment to him. And of course, our Raigad district has taken the cases very wonderfully. Compliments and congratulations. And thank you, Dr. Hushar. So it was a very rare case. The theme of the subject or it kind of meetings is to really approach it rightly. And that's how it went well. Thank you very much. I think it was definitely a complete new thing for us. Not very commonly heard. So it's a good learning lesson for all of us. Yes.
Right, sir. So I wanted to apologize for the same thing. I started by saying that I want to apologize for many things. One of that was the case, the assignment was given a little late. And the second apology was for choosing a very rare case, but then I did not want to mention that the case is very rare. Maybe next time we can have a.
No, it was a good learning lesson, Tushar. Don't take it in the wrong way. It was a wonderful learning lesson. This platform is not built for routine things. This platform is to learn something beyond what we do in day-to-day practice. So definitely it is, we do want these kind of cases in future, intermittently, not regularly, but at least intermittently. Ideas to build up a kind of a, like the previous case, we had some clues there itself. Here we made to the clue that there is a diabetes. We made to the clue that there was megaloblastic anemia. But putting it together, even the genetics could not solve the problem. That becomes a really big challenge. And then obviously comes with the wild guess what people a time responsive. I'm sure very few of us have seen these cases. We only heard of them. So obviously, if your eyes have not seen, the mind don't think of it. So that is how it perhaps goes up. But absolutely, overall, it's a very good case. Thank you for that.
Hello. Dr. Nani Vadekar, sir, your comments, please.
Yeah, thanks. Once again, a fantastic case. And I was almost about to go to say that eyes don't see what mind doesn't know. I think this is the theme which we have talked about in the NCPID conference also. But rightly said, when we talked about the first transfusion, my guess or thinking was slightly in a different fashion. Why would that lead to a diabetes later on? Forget about the fact that Tushar is presenting so a child who is got a tachypnea with no respiratory signs. So it had to be metabolic acidosis. It has to be some diabetes, be insipidus or mellitus. But the fact that this child came with drowsiness and other things probably was diabetes mellitus. But then why the anemia and why these transfusions? So if we go to see that MCV and the low platelet count, it was suggesting that we are definitely dealing with megaloblastic anemia. And in case we are talking about megaloblastic anemia, then if your vitamin B12 and folic acid is normal, then we have to think of something different. And then thiamine, of course, we have not seen any cases, we have just read in the textbooks, but then that was the only thing which we would have thought of. But then again, a fantastic case. But the approach by the Raigad team was perfect because they correctly diagnosed diabetes. There was no problem there, and they insisted on the indices, because when we say anemia, it doesn't just remain at anemia unless we see the CBC, MCV, and the peripheral smear. That's the time when we are going to see some amount of iron deficiency anemia in any child, especially the child who's breastfed and not given not much of complement diet is expected. But the child who's got anemia of significance, these indices are going to give us a clue, and that slightly higher MCV was definitely a clue for megaloblastic. So their approach towards this was definitely great. So overall, both the cases were fantastic. Again, clinical examination will, and the history, of course, is going to clinch the diagnosis many of the times. And again, the approach was very good. Thank you. Mahesh, you want to say something?
No, I think we did everything.
Yeah.
In fact, both the cases, unlike only history, it was labs which were definitely mandatory. This is one case where perhaps you could not have cracked without a proper lab.
Not in this case. Yes.
Tushar.
Yeah.
Yes.
Tushar, yeah. Very good case. But I want to add to this. Any diabetes which starts in the first 6 months is probably a monogenic diabetes. Okay. And in India, there is one laboratory in Chennai which does a genetic workup free of cost. Dr. Mohan's diabetic laboratory.
Correct.
That is in Chennai, and you can get this monogenic diabetes www, and you can get all the details how to send the sample. Right now, I have a patient which is 1 year and his diabetes, and he's probably started 3 months, 9 months, but still I am sending that sample to that lab. A monogenic diabetes. What is the importance of that is, once you get the monogenic diabetes, few of them are treatable by drugs, by sulfonylureas, and you can shift and you can avoid injection insulin, and you can shift to the oral diabetic. KCNG, I don't know about KCNG or ABCC. We can shift from that insulin to the sulfonylurea, but there are groups of disorder in monogenic diabetes where we can avoid total injection. That is the importance of doing a genetic test in less than 6 months. And one of them is thiamine also. Thiamine responsive, and it's this. I had a discussion with Dr. Anurag Bajpayee. That's why I have written thiamine directly. Sorry for that. But thiamine response, because it is a treatable cause with the drugs. That's why you should know this condition.
Yes, but the requirements will come down, Mahesh. It won't just go. The
No.
As he has shown, not in all, but as you correctly said, there are few monogenic diabetics which can be shifted to the oral drugs. Yes.
Yeah. Comment by Dr. Tushar on this.
Yeah. So yes, so we have had many cases of KCNJ11 and ABCC8 diagnosed commercially in India also and by Exeter also, where we have shifted them to sulfonylureas. Many of them, in fact, have transient neonatal diabetes, where by the end of 6 to 9 months they just reverse back, without any treatment. So yes, genetic diagnosis is important. And with regards to KCNJ11, ABCC8, yes, they can be shifted to sulfonylureas. They have some cognitive issues later on, but they are insulin free. With regards to TRMA, we have very limited data, but whatever studies are available, some of them do come out of insulin totally, but you need mega doses like 100 to 150 milligrams per day. Absolutely. But some of them do come out of insulin very well.
I came to know about this condition TRMA, thiamine responsive. In one of my case, he has a severe metabolic acidosis with ketosis, with lactic acidosis, and the blood sugars were not that high, in 400, 500. It was just 150, 200, 250 maximum. And this he settled down with the correction of acidosis. Then we thought of methylmalonic acidemia, because it can cause hyperglycemia sometimes with ketosis. And we have sent, and at that time I came to know that thiamine responsive, we added thiamine also in that case, but it turned out to be something else.
Dr. RD sir.
Yeah.
Karun
wonderful cases, and more important is wonderful approach. And Tushar, it was a great learning experience, very nice case, and you took it absolutely clinically. At the end, to have the interest, it is wonderful. I had 1 or 2 points over there at your MCHC, because I would have diagnosed this patient as spirocytosis. Its MCHC was more than 34, and patient needing again and again transfusion. So that was one thing, but now you have proven it, and this thing, that diagnosis is there. But initially, I would have thought of a pyruvate kinase deficiency or membrane disorder or spirocytosis, because MCHC was there. And secondly, about B12, a single dose of vitamin B12 can give you B12 levels normal, absolutely. So in such cases, if you strongly have clinical suspicions, it is better to do methylmalonic acid levels, MMA, which doesn't get corrected by B12, and also homocysteine levels. That will definitely tell us whether patient had B12 deficiency or not. So these were a small suggestion or doubts from my side. Probably this I would have worked up that case with flow cytometry or spirocytosis before jumping on any clinic full exam or clinical exam sequencing in this child. But particularly, definitely, since it was retrospectively a neonatal jaundice, neonatal diabetes, a monogenic diabetes has to be ruled out. Yes.
Right.
Just one comment, if you allow. That initial respiratory distress, we don't know what was it, but if on the background of thiamine responsive syndrome, there is a category of pulmonary hypertension who responds to only thiamine. That's a new development. So we don't know whether it was pulmonary hypertension, which was empirically, I don't know where it was treated, but even that can be thought of, whether it was thiamine responsive pulmonary hypertension. That's a known category, especially in newborns. When there is a refractory pulmonary hypertension, thiamine sometimes works in few babies, and it's very well accepted.
Is it likely that somebody has given some multivitamin drops at that time, and that has indirectly, without knowing, that has got corrected? That nobody knows.
Maybe.
I will add to that.
There are commercial available drops, neonatal or infantile drops, which has contains thiamine.
Yeah, but typically thiamine.
Therapeutic doses of thiamine.
Yeah, but that
Yeah,
should
but anyway,
be in a higher dose. Na?
Thiamine responsive pulmonary hypertension do not present in neonate as such. All of them are present at the end of 2 months, almost 2 to 3 months, and it is more common to the Bangalore side, Tumkur side, where the polysaccharide is used. So a mother is deficient in thiamine. That's why baby is also deficient in thiamine, and they will present with typical respiratory distress or bronchiolitis thing at the end of 1 or 2 months, not at neonatal period.
Mahesh, I differ with that. We have seen 2 cases in an early neonatal age group.
Common
So maybe the
presentation
same
is at the
reason
end of
that
2 months.
maternal deficiency, but we have seen at an early age also.
Yeah, but most common presentation is at the end of 2 or 3 months, because we should know this clinical presentation, because if there are no crepes, no wheeze, and he is tachypneic and treatable cause, and they will present with like a congestive cardiac failure like thing. A right-sided congestive cardiac failure.
Tushar.
Liver will be there.
Tarun sir,
Yes,
you
yes.
want to give comments?
Yes, Tushar. Yeah. Considering consanguinity, diabetes, mellitus, and deafness, wouldn't you consider dead mode as one of the differentials? Because diabetes insipidus presents a little later in life, and such a child with a such early onset of diabetes mellitus with consanguinity, I think so dead mode would have been a good differential.
Yeah. So my 3 differentials at the beginning were dead mode. TRMA was nowhere in the picture until the deafness came forward. But 2 things I was thinking of. One was the dead mod. Rarely they have come that early, and second was mitochondrial diabetes, because mitochondrial diabetes can also come with neonatal diabetes and deafness with some microcephaly and developmental delay. So I had kept initially dead mod and mitochondrial diabetes as
The
the
vision was
possibilities.
fine na, with this child.
Vision was fine. Yeah,
Yeah,
it
so-
is still fine except for nystagmus. The fundus was normal. Fundus and vision was normal.
In infantile period, blindness can present as just nystagmus actually.
Yeah.
So actually, when you were discussing nystagmus, I was thinking about dead mode, but I didn't know whether there was any genetic test to confirm dead mode. How do we confirm?
Yeah, we
it.
have commercial panels available. In this particular case, since the child belongs to a very resource limited condition, we did not in fact order clinical exome. I wrote to Dr. Eliza DeFranco at Exeter to specifically look for TRMA gene. That's it, and she replied back within 2 weeks that it's positive.
Okay, great. Thank you, Tushar. Lovely case.
Yeah. Thank you.
Yeah.
Any more comments?
Yeah, one more thing is that nystagmus, it is out of context, but is nystagmus if everything is normal neurologically, otherwise child is neurodevelopmentally normal. The high refractive error is one of the important reason for the nystagmus at 5 months, 4 months with uprolling, but no convulsions, no hypertonia, no neurodevelopmental. So that we should. I had 2 patients where ophthalmologist said there is no refractive error, and Dr. Samdani did say it is 13 and 12 was the refractive this thing. So that one, it is of course rare, but I had the 2 cases in last 12-15 years. So those were both were diagnosed by Dr. Samdani in Hinduja. So that nystagmus, if everything is okay, then we have to think of high refractive error.
Neha.
Wonderful. Congratulations all.
Thank you.
Yeah, it was an excellent session today. And I think with this, we'll wrap up today's session. And I would like to hand over the dais to Dr. Neha Singh for further proceedings.
Yeah, thank you, Dr. Trupti. On behalf of Maha IP, I, Dr. Neha Singh, first of all, would like to thank respected Dr. Vasant Khalatkar sir for being our guest of honor and giving his blessings today. Even being so busy, he managed to join us. I thank our experts for today's case challenge, Dr. Narendra Nanewadekar sir and Dr. Mahesh Moite sir, for giving the expert comments, which were very inspiring and helpful. Also would like to thank both our case presenters, Dr. Shushruta Deshmukh ma'am and Dr. Tushar Godbole sir for presenting to us such interesting cases and that too preparing in a very short notice. I thank and congratulate both the teams of today, Dr. Sunil Shet sir, Abha sir, Dr. Rajendra Chandorkar sir and Dr. Vipul from Team Raigad, and Dr. Mahesh Kore, Dr. Uday Patil, and Dr. Venkatesh from Team Kolhapur IIP for your participation in the last hour invitation. They were very, extremely wonderful and active in cracking their cases. I would thank Dr. Pramod Kulkarni sir for his all support and time sir gives for the cases and guiding our presenters. Thank you so much, sir. I thank our Maha IP President Dr. Ramakant Patil sir and Secretary General Dr. Amol Pawar sir for starting again this favorite case challenge again and giving myself, Dr. Anjali and Dr. Tripti the opportunity to conduct the program. Also thanks to our 5 zonal coordinators, Dr. Rajendra Bhatke, Dr. Anjali Gokand, Dr. Deepa Firke, Dr. Ravindra Sonamre, Dr. Naresh Tiade for giving their full support. I also thank Dr. Krishna Rao Gangude or MC Observer for today for giving us points. Thank you, Dr. Deepa Firke ma'am and Tripti for moderating today's case challenge, and also thank Pallavi ma'am for all the technical support. Thank last all the attendees on Zoom and YouTube Live for joining us today. Thank you all.